stream event as we discuss what you can do now to prevent Alzheimer's disease. My name is Ed Bottomley with the Michigan Medicine Department of Communication, and our panel today includes 3 experts who will help answer questions about brain health and how to prevent Alzheimer's disease. And I'll turn things over to our 3 experts for some quick introductions. First off, let's go to you, Dr. Paulson.
Hi, I'm Hank Paulson. I'm a neurologist and director of the Michigan Alzheimer's Center. And in my clinical work, I focus on people who have cognitive concerns.
Thank you so much. Next up, let's go to Dr. Roberts.
Hi, I'm Scott Roberts. I'm a faculty member at the U of M School of Public Health and part of the Michigan Alzheimer's Disease Research Center focused on public education and outreach.
Thank you both. And also Dr. Jones.
Good afternoon, everyone. My name is Lynette Jones. I'm assistant professor in the University of Michigan School of Nursing, and my work focuses on self-management of hypertension in African-American women in order to reduce health disparities affecting the Black community.
Thank you all 3. Really looking forward to this chat. Let's just do a little bit of housekeeping first. You can submit questions at any time for our panel to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video wherever you see it, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can also send us a private message via the relevant social channel that you're viewing this on. If you can't stay for the whole chat, or want to share the recording with a friend, a video of this chat in its entirety will be available on our flagship Michigan Medicine YouTube channel. So let's move now to our questions. And the first question that we have is asking about defining dementia versus Alzheimer's. So this question, let's start off with, what is the difference between Alzheimer's and dementia? And if we could go to you first, Dr. Paulson.
Sure. Dementia is the term for when someone has impairment in cognitive domains that is significant enough to impair your normal activities. It's kind of a vague term, and dementia can be caused by lots of different things, and there are many different forms of dementia. Alzheimer's is a specific type of dementia. So you can think about dementia as an umbrella term under which there is Alzheimer's and other forms of dementia. I often think of it as like a fruit bowl. If you got a fruit bowl, it's got all fruits in it, right? Maybe there's 6 or 7 apples and there are 3 bananas, etc. Well, the apples might be the Alzheimer's. They're fruits. The bananas might be one of the other forms of dementia, like Lewy body dementia or frontotemporal dementia. So there are several different forms of dementia. And oftentimes, when we look at someone's brain after they have passed away from dementia, they have more than one contributor to their dementia.
Thank you for that. I don't know if either of our other 2 experts want to jump in.
I can just add, being in a school of public health, it's certainly dementia has become a very important public health issue, given that I think we have over 6 million adults in the U.S. today, specifically with Alzheimer's and more with broader forms of dementia. And given that, I think we're going to get into risk factors, but given that, we have so many more older adults these days in the United States, I think those numbers are projected to grow over time unless we can do more on the prevention front. So certainly a very important public health issue.
We also have another couple of other questions. I think you've touched on these a little bit, Dr. Paulson, the other types of dementia. But one of the other questions we have, how does it differ from general memory concerns?
That's a very good question. All of us have glitches in memory once in a while, right? You might forget the name of someone, or what was the name of that actor in that movie, or what is the name of that person who lives down the street, or I can't remember where my keys are this moment. That is normal forgetfulness, and that may increase a little as we get older, but it's quite different from someone who forgets entirely that they had a vacation 3 weeks ago, or can no longer manage a budget as opposed to occasionally missing a check. So it's what we're talking about is the degree, the severity of the memory issues, that they are significant, daily, and affecting large episodes and not simply occasional specific events. It's something we all experience, And as we get older, and I'm now 63, so I'm thinking about this. If I forget something, am I concerned that that might be dementia? Well, if it's forgetting that George Clooney was the actor in that movie, no, that's not an issue. But if I can't remember that I had dinner 3 nights ago with 6 people, that's a concern.
I see other two experts nodding. Go ahead, Dr. Roberts.
Yeah, I was just going to add, a lot of times people are trying to figure out this distinction and wondering, well, when does something rise to the level of when I should maybe seek formal evaluation? So I wanted to mention one great resource in this area, the National Alzheimer's Association on their website, www.alz.org. They have a section of their website specifically devoted to this issue, and they have a resource on the 10 warning signs. And so it's a great educational resource for our audience to consider if you haven't seen it already. It helps kind of define, well, when is something maybe rising to the level of where you probably should try to get it checked out versus, as Dr. Paulson was mentioning, a lot of times we're just, having minor issues that are not really a cause of clinical concern.
I just can't agree enough that that Alzheimer's site and those 10 warning signs is a very good thing, very easy to read and worth checking out.
Thank you. We'll put that in the comment section. Dr. Jones, do you have anything to add?
Yes, I do. I completely agree, both Dr. Roberts and Dr. Paulson. And I also think those are a good foundation for a conversation to have with your provider. And so if you have any questions, that's a good starting point. So when you go in and talk to whoever is helping you to manage your care, you can ask some questions and say, what do you think about this? I have concerns about that. And I think it's a great conversation point.
Thank you. Thank you all three. Let's move on to our next question. We're going to talk about risk factors that perhaps can't be changed. The first one we have up, what are the factors that contribute to Alzheimer's and dementia? I could pass that to you first, Dr. Paulson.
Yeah, I think of many diseases as having many elements that contribute to it. And I often think about the genes, environment, landscape. Some diseases have much more environmental contributors and others have more genetic contributors. I think that Alzheimer's and other dementias sit squarely in the middle, where genes play a role and environment clearly plays a major role. So we can talk about risk factors that are modifiable, that we might be able to change and reduce our risk or help our cognition, and others that we can't change that much, including genetics. I'll let Dr. Roberts speak about the genetic components, but I will say that we know that the degree to which you've had strong education, that you continue to use your brain in stimulating ways, if you sleep well, and if you avoid certain diseases like diabetes and hypertension. It's hard to avoid those. And if you have those diseases, be treated well for those. These are all things that can be reducing one's risk of developing Alzheimer's and related dementias. The genetics is a different story, and I'll turn it to Dr. Roberts. I'm sure that Dr. Jones has comments on this as well.
Yeah, well, thanks, Dr. Paulson. So we mentioned aging already. We can't do anything about the fact that we all age. Biological sex is an important risk factor. So women are at elevated risk for Alzheimer's and other dementias. And then genetics is another important thing that we can't really change. And so just to elaborate on that, there are some very rare types of Alzheimer's disease where if someone possesses what we call a genetic mutation, then one will almost inevitably get the disease, and sometimes even in one's 30s or 40s. So if you ever saw the movie Still Alice, that was the case in that Hollywood film. That the protagonist had, she developed Alzheimer's at age 50, and she had one of these rare mutations. Fortunately, they are very rare, so they account for maybe like 1 to 2% of all Alzheimer's cases. But I did want to make that point because occasionally we do see that. And then you see, usually in those kinds of families, you would have multiple family members affected in a very earlier age of onset. There's also another gene to be aware of called ApoE. And so we all have an ApoE gene, but there's a certain variant referred to as this E4 type. And so if someone has a copy of the E4 allele, 1 or 2 copies, inherited from our parents, then one is at elevated risk for Alzheimer's. And so that ApoE testing is not usually done a lot in clinical practice, but it's done a lot in research, and it's actually become available now and through direct-to-consumer genetic testing. So it's been in the news. You may have heard of the celebrity who plays Thor. Sorry, I'm like keep making Hollywood references here. You can tell where my own brain is. But Chris Hemsworth, came out as he had this ApoE44 genotype, and so he was at elevated risk. So I think it's important to recognize that the genetic factors are relevant here. But on the other hand, it's not destiny. So you could have that ApoE genotype that I mentioned and still never get the disease, and you could get the disease without having that specific genotype. And then maybe Dr. Jones, you wanted to, we were talking about hypertension. I know that's your area of expertise. Maybe you might want to talk about how managing that can be relevant here.
Absolutely. I think I'll save it for the official modifiable ones. And so when we get through that question, I'll definitely address that. Thank you.
Thank you. And thank you, Dr. Jones. You know what? That's going to be our next question. What are some modifiable risk factors?
Yes. So I've had the amazing opportunity to work in the Alzheimer Center. Even though I'm not an Alzheimer official researcher, I've got to think a lot about prevention from the perspective of blood pressure control. And so one of the things is to know your levels, right? So a lot of folks do blood pressure screening, and they'll say, oh, no, thank you. I don't want to know. And so it's really important to know, just like I talked about having a conversation, seeing your provider. If you're diagnosed with certain conditions, managing those conditions like Dr. Paulson talked about, or even just from a prevention standpoint in blood pressure and diabetes, because those are major risk factors for dementia. So either controlling your blood sugar, controlling your blood pressure, and the ways that we do that by regular exercise, by eating a healthy diet, physical activity to control, maintain, or reduce your weight, depending on what level you are at. And there's other things as well. Adequate sleep is something that I think is part of kind of the environment, right? So what is your sleep hygiene? Do you have a routine? Making sure that you get enough sleep each night. And then thinking about things like social engagement. I can't remember if it was Dr. Roberts or Dr. Paul that talked about mental stimulation. And so there are things that we can do to reduce our stress, to make sure that we are staying engaged in a social environment. And all those things are really important to make sure that you're not isolated or not creating a stressful environment, which could increase your risk. And so there's no one specific way, but being thoughtful about all of these ways that you can reduce your risk, and some things that you can really commit to will help you to stay in a reduced and safer space rather than not considering any of these factors.
I just wanted to add, Ed, that when I see people in the clinic, I will tell them that I wish I could write a script for you to exercise every day, because I think that'll be a better script than something I might provide you, like a medication to enhance memory. If you were out there getting your heart rate up and exercising every day, that, for reasons I don't understand, but I know is true based on the data in the literature, makes a huge difference in brain function. And I'm not saying it's going to eliminate dementia, but it can certainly help one's brain work as well as possible as we age, whether or not we're encountering dementia.
Dr. Jones definitely mentioned this. Both of our other two experts definitely mentioned this. Could you go in a little bit more detail about mental stimulation? I'm thinking about my grandpa who still plays Sudoku. Is that the kind of thing you're talking about?
Yeah, it's a good point. I'm not talking about a specific thing. I'm not saying it needs to be Sudoku or it needs to be crossword puzzle or that it needs to be trying to remember things in some very organized way. I honestly think the best form of mental stimulation is talking with people. I think it not only stimulates the brain, but it is a social engagement, which can make a huge difference, and it can lead to improvement in sleep and other things. It really comes down to what that person likes to do. If someone doesn't like to do Sudoku, they're not going to get a lot out of that. It's not going to help their brain function, but they can find something that can stimulate them in some way. I find doing this stimulating, right? This is the kind of thing that keeps my brain working well, is that I'm engaging with people online and talking about things. But if I'm not doing that, I'm reading a book or I'm reading some article about a scientific discovery. But really, I think it can vary a lot from person to person. There's no prescription. There's no certain game that you should buy online or get in the store that makes your brain better. I'm sure that Dr. Roberts and Dr. Jones have comments on that.
Yeah, I could just add, I think those are great points, Hank. I think the idea that I would like to stress here is that, you know, a lot of these things are good for you, not just with dementia prevention in mind. You know, I think as Dr. Jones knows for sure, there's a new slogan that's been making the rounds of like, what's good for the heart is good for the brain. So a lot of things we're talking about, these health behavior change, might not just reduce your risk of dementia, but might also be helpful for reducing risk of heart disease, cancer, other common chronic diseases. And perhaps even more importantly, a lot of them are key, as Hank was alluding to just kind of a fulfilling life and are good for our mental health and well-being. And so I think that idea of social engagement and exercise was mentioned earlier. That has a great positive effect on mood, for example. So a lot of these things, you get a lot of bang for your buck. I think some of them are challenging to implement. So diet and exercise, it's hard to make really sustained changes. And you know, the Mediterranean diet's been talked about, for example, as useful. But and a lot of them require, you know, may require a lot of resources that people may not have. So I think we need to recognize that some of these behavior changes, you know, are challenging, and we can hopefully think of them not just at the individual level, but thinking about, well, what can we do more broadly in society to kind of enact policies and think about, you know, what's the built environments that people live in to kind of promote some of these behavior changes as well.
Let me follow up on what Scott said there. What's good for the heart is good for the brain. I failed to mention earlier, in different types of dementia, vascular dementia. And, you know, you think about your brain as a bunch of brain cells, neurons. But in fact, the brain is as rich with blood vessels as anywhere in our body except for the heart. You can't think without blood coursing through that brain at a super high rate. And people who have heart disease often can also develop brain vessel disease that can snip off little bits of the brain here and there. And that can be what's called vascular cognitive impairment or vascular dementia. And the reality is, when people develop dementia and we look at their brains, we can see signs of vascular change as well as Alzheimer's or some other form of dementia.
Dr. Jones, go ahead.
Yes, if I could just reiterate one really important point, it's what you can and are willing to participate in, right? What routine are you willing to commit to? And so thinking about, especially exercise, very difficult to implement. But if you think about it from a risk standpoint, you're literally reducing the amount of sugar or glucose in your bloodstream. You can literally bring that and exercise that part out. So that does help with glucose control. And then there's also evidence to show that when you exercise, you reduce your cholesterol level, you reduce your blood pressure, you may promote the growth and maintain healthy brain cells and improve cognitive function, probably because you're improving your blood flow. So while it's difficult, I think thinking about what your particular risk is and what you commit to, thinking about those underlying factors that you're really, like Dr. Roberts said, you're getting a real bang for your buck. What can you commit to? And so some of the things I talk about with self-management, particularly, you know, if you feel like your neighborhood might not be the safest, or if you have some other concerns, you can, you know, do exercises in a chair. You can look on YouTube and see if you might like yoga. There's different ways to expose yourself to different things that you might not be able to necessarily go out and do. So I highly recommend when I talk to patients and participants that they consider YouTube, social media, looking to see different things that are out there, following someone who may be similar to you in background and size, and really seeing that if you can find something that you like and that you can commit to, because behavior change is very difficult.
And if I can follow up on some of the potential, modifiable factors that we haven't touched on. One of those is limiting your alcohol intake, right? I mean, alcohol is something that people enjoy socially, but if you drink too much alcohol and you don't eat a healthy diet, that can injure the brain. That can cause memory loss. And so that's a very important point. Smoking likewise fits in with the hypertension and everything else. Avoiding cigarettes, avoiding smoke, and reducing or keeping to a modest amount your alcohol is very important. And people are often concerned, well, what about, traumatic injury to my head? What about that concussion I had when I played hockey years ago? And clearly, head injury can contribute to later life dementia. We've heard about people talk about pro football dementia or chronic traumatic encephalopathy. That's another form of sort of delayed brain injury that can be progressive and cause dementia. Often we hear about it in people who were professional athletes or who did contact sports for a long period of time. In general, a small concussion once in your life is probably not going to make a difference. But if you've had repetitive concussive injuries, that can contribute as well. And another thing that there's a lot of people at the University of Michigan studying is the relationship between hearing, auditory cortex, and cognitive performance. We don't really understand that fully. I mean, it might make sense that if I say it's important to be socially engaged and you can't hear anything, it may reduce your social engagement. That could contribute to your being isolated and having cognitive impairment. But I think it's more than that. I think there are other ways in which the way that hearing stimulates the brain is important in helping to reduce risk. Now, that doesn't mean that people who are deaf or people who've lost hearing inevitably get dementia, but there is some relationship there that we're still trying to figure out.
Yeah, thank you so much. Dr. Roberts, I see you on.
Yeah, just to chime in on that, I was amazed when I saw the statistics on, people who could potentially benefit from a hearing aid who don't, actually use one. And I think part of that are some maybe real access issues, but I think a lot of times it's at least if in my family, it's more like a pride issue for at least the men in my family. And so I've encouraged some of my relatives to, the benefits are going to be great just in terms of being able to participate in everyday conversations. And so if there's anybody in the audience who's been kind of maybe knows that it would be helpful, but for whatever reason has been reluctant, I think maybe this link between kind of hearing loss and cognitive issues that Dr. Paulson is raising is an important.
None of us here are experts on hearing aids, but they have become more available, cheaper, and better. And I've had personal experience from friends and family who in the last year have found hearing aids that finally work well for them, so that it's not a jarring experience and they're engaging in the world in ways that they hadn't been able to do for a couple of years. That can only be a good thing.
I think it's also important to think about prevention as well. And so we talked about head injury. So if you're participating in a new exercise, do you need a helmet? Is that important? What type of protective gear do you need? As well as with hearing loss. So how loudly are you listening to your music while you're exercising? What's the level that you have your AirPods on when you're on the phone? So thinking about those things from a prevention standpoint too. Can you maintain your hearing? Can you maintain your brain health by wearing protective gear and thinking about those things in advance before you participate in a particular activity?
Thank you for that, Dr. Jones. I think I'm going to push the next question to you as well. Do some groups have a higher risk for Alzheimer's and dementia?
The answer is yes. I think we've all talked a little bit. So women have additional risk for Alzheimer's disease. And then if you think about health disparities, and so we talked about controlling your blood pressure and controlling your blood glucose. So if you have hypertension or diabetes, that means you have an additional risk for Alzheimer's disease. And so if you think about that, excuse me, there's communities of color, that have additional risk for these particular diseases, and therefore have additional risk for Alzheimer's. I also want to point out too, and I think we're going to talk about this a little bit later, but I'll highlight now. We have lots of research on mostly white men. Studies have been conducted on, or either elderly men or men that are in college. And so if you think about communities who maybe are not in the college campus, or communities of color who have, suffered injustices in the name of research, like the Tuskegee experiment, and have concerns about participating, but we have less data to guide our recommendations and guide our interventions for these particular populations. So I'm going to talk about it later again, but I just want to say now it's really important to partner with the researchers in the Alzheimer's Center, researchers of color, ask questions, but it's really important that we participate in studies so that we can learn more about other communities, and so that if there are differences, we can make those specific recommendations for additional communities that are at risk.
Thank you for that. Dr. Roberts, go ahead.
Yeah, Lynette's making some great points here that I'm glad to hear. And I guess I would just elaborate on, I think the challenges are not just that certain groups are at higher risk, but then some of those groups also, face disproportionate barriers to care as well. So whether it's, being insured, or whether it's having access to a specialty provider like a neurologist, I think the same groups that are at the elevated risk might also face greater barriers. And so trying to address those from a policy perspective, I think is going to be important. And so I think also thinking about just how can we educate and empower groups to take action. It's not, there are no easy answers here, but I think these disparities are multi-layered. And so I think I'm glad we're talking about them.
Thank you, all three. Let's move on to our next questions. I'm going to ask you a couple about current treatment caregiver options. So the first one, I'll push to you first, Dr. Paulson. What are the current treatments available for Alzheimer's?
Well, above and beyond the measures we already talked about in terms of how one lives one's life and has your treatment for your diabetes and hypertension and cholesterol, if you have that, there are some medications that are what we call symptomatic medications. They can modestly improve one's memory. There are two different classes of these medications. One class is the cholinesterase inhibitors. People may have heard of them. Donepezil is one of those, for example. The brand name for that is Aricept. There are several different versions of these cholinesterase inhibitors. And there's another symptomatic memory enhancing medication called memantine with the brand name Namenda. They are very different drugs, the cholinesterase inhibitors and memantine, and they are not for everyone. They are helpful in some people. And when I provide it to my patients, I say, I don't know if this is going to make a difference, but we can give it a shot and see what you think. They can be helpful for not only Alzheimer's, but one of the other forms of dementia, which we haven't talked about much, Lewy body dementia, where cholinesterase inhibitors can be quite helpful. Those are symptomatic treatments that can, help with the memory. And of course, as disease goes on, people can develop depression. It can be part and parcel of the disease, or maybe in response to having the disease. People can develop irritability or behavioral changes, or they might have, in some diseases, particularly Lewy body, they may have delusions where they have thoughts that are not grounded in reality, or they may see things that aren't real, visual hallucinations. And in those situations, we may try with care, with caution, we might try some antipsychotics. All of what I just talked about are symptomatic treatment. Someone has a symptom, some particular type of behavior or symptom, and we try to treat that. We don't have anything that cures Alzheimer's. We don't have anything that cures Lewy body or frontotemporal dementia or vascular dementia right now. We do have now interesting, tantalizing leads that anti-amyloid therapies, amyloid being one of the two key proteins in Alzheimer's, that anti-amyloid monoclonal antibodies may be modestly helpful in reducing the rate of progression of disease. Again, not a home run, not a disease reverser, but maybe a single, maybe if you use the baseball analogy, a little bit of a hit. These are anti-amyloid therapies. One of them is lecanemab, recently received accelerated FDA approval and looks promising. Now, when we talk about these kind of disease-modifying therapies, I'm hoping this is the first of many that'll come in the next 20 years, and that they'll be better than what we have now, and that there might even be combination therapy that truly does stop the disease in its tracks. We are not there now. And while I'm very excited about the fact that we, for the first time in, frankly, ever, have something that is shown to slow the rate of disease, there are going to be challenges that come with that. And we can get into this, but anti-amyloid therapy is a monoclonal antibody. That is a biological therapy. It's inherently expensive. Lecanemab is going to be $26,000. Insurance might or might not cover it. Who will be able to get that? Will there be access to that kind of a medication across all societies, all communities? I hope so, but that's a concern. And how will we as a healthcare profession deliver these therapies? Because these are not a pill that you take. These are infusions that you get every 2 weeks, or maybe in the future every month, or maybe less frequently than that, you get in an infusion center. So there are lots of logistical issues that come with this, and potential barriers to treatment for some people. So I don't want to be a downer. I'm not trying to say this is bad. I'm excited about the fact that we're moving toward disease-modifying therapies. And I think for some of the rare forms of disease that Dr. Roberts mentioned, particularly for the frontotemporal dementias, we might find some things that are curative, but it's still a work in progress. I've said a lot. I'm going to stop because I'm sure that both Drs. London and Roberts have things to say on this point.
I think you covered it nicely. I think it is tricky, though. There's a lot of controversy and excitement at the same time over some of these new therapies. And I think just our audience can maybe stay tuned, because I think we'll have some big decisions in the coming few months. Like, will the FDA fully approve? There's a new treatment on the horizon called donanemab, where we're all waiting to hear more at the big international meeting this summer in Amsterdam. Like, what will those clinical trial findings show? There'll be some big decisions, like, will Medicare provide, full coverage for these new therapies? So I think all of that will start to be worked out, I think, in the coming calendar year. So I think our audience may hear some more of these big news stories about these developing treatments. But as Dr. Paulson did allude to it, they are going to be complicated to administer, not just in terms of the infusion issue, but also, there'll be monitoring for side effects. And so I think it'll be recommended that, for example, that people get MRIs to see there are some side effects from these new medications that might cause, swelling or bleeding in the brain. So it certainly is very different from, take 2 pills and call me in the morning. And so I hope we can kind of work out some of these intricacies, because I do think the good news is, it's not been for a lack of looking. I think we went almost 20 years between FDA approved medications for Alzheimer's in particular. And now all of a sudden we've had a few in the past couple of years. And so I think there is a good reason for excitement, but also trying to harness this new technology will be a challenge too.
Dr. Jones, I saw you nodding a bit. If you have anything to add.
No, I agree. I just think, conversations like this one, additional conversations of what can we do as providers and as scientists to be thoughtful about the logistics, like Dr. Paulson said, as well as what Dr. Roberts talked about is who has access, how is it fair, is it equitable across communities. I think those are really important conversations. No easy fixes, but it's important to talk about them and to continue to have that conversation until we achieve health equity for all communities.
Thank you. I'm going to move on to the second part under this theme. The question is, are there resources for caregivers of people with Alzheimer's disease? Dr. Roberts, let me pass to you first.
Yeah, there certainly are, and at many levels. So I mentioned, the National Alzheimer's Association earlier. So they're a great resource in this space. They have, chapters across the United States. We have a very strong Michigan chapter. And so that group has a variety of services. So, they have like a hotline for caregivers to call in, I think a 24/7 hotline for caregivers if they have kind of emergent concerns. They've got kind of a range of caregiver support groups for people to sign up for. They've got a lot of education materials. I think some of these kinds of materials we also see the National Institute on Aging that funds a lot of our research has a website devoted to caregiver resources. Our own center, we have a variety of programs for caregivers. So we have support groups for caregivers. A lot of these, because of COVID, we've moved virtually, and we found that it actually has been easier to conduct these virtually, given that for many caregivers, it's a challenge to get somewhere. And so we have support groups for dementia caregivers, including specifically for Lewy body dementia, because a lot of the services we've been talking about have been geared more for Alzheimer's dementia caregivers, but our center also has a focus on Lewy body dementia because sometimes the caregiving issues might be different given the different symptom profile of that condition. We also, and I think there's other examples of this beyond just our center, but our center, we also have a several week kind of structured education and support program for newly diagnosed patients and family members. I think the complaint in the field has been that in the past, maybe we had what's called diagnose and adios, that they get this challenging diagnosis and then the next formal follow-up with any provider is several months down the line. And so our center has tried to create a structure where patients and families get some specific education in a weekly or monthly kind of staggered way that can provide some support in that interim phase. So there's a range of these out there. Of course, there's a lot of self-help books as well that I think have been useful for a lot of caregivers. So it's a very challenging role, as I'm sure our audience knows. But the good news is I think there are a lot of different kinds of resources, and I imagine Lynette or Hank might want to add to what I've said.
I'm just going to quickly say I'm really proud of what we've done as a center, but what the Alzheimer's Association does, and the Association for Frontotemporal Dementia, and the Lewy Body Dementia Association, all of which have really good websites with information and support caregiver and care partner support groups, are really, really important. I'll turn it over to Lynette.
Yes. So in the same vein, I just want to reiterate some of the things that we talked about today as far as risk. Your risk is increased when you are a caregiver. And so while your time might be limited and your focus may not be on yourself, I just want to reiterate the fact that you should consider yourself, because you can't pour into someone else if you're not pouring into yourself. So maintaining your blood pressure control, maintaining your glucose control, your exercise levels, your diet levels, your social engagement, which is why these caregiver support groups, I think, are very helpful. Those things are very important, because if you don't maintain your own health, you are at an increased risk because you're not, monitoring your blood pressure closely. You're not thinking about your physical activity because you're caring for someone else. but we have to find ways to self-manage those things for ourselves. Otherwise, we're not going to be good caregivers for the person that we're taking care of.
Thank
Yeah,
you. That's an excellent point. Sorry to butt in, but any of our viewers, if you go to our comment section, you'll see all of these resources being linked to as well. Sorry, go ahead, Dr. Robert.
Oh, no problem. Yes, I think Lynette's self-care comment is really important to underscore here. I think it's something that in our own caregiver support programs, we really pay a lot of attention to. We have a fantastic social worker who's an expert, for example, in mindfulness-based stress reduction. So teaching caregivers stress management techniques to help manage the stress that will inevitably come from the caregiving role. I think that kind of example is important to keep in mind here. And I think it's interesting. A lot of times, what's most stressful for caregivers are not what we think of as the classic symptoms of Alzheimer's and dementia. It's not. Oftentimes, it's not the memory loss that's the most troubling. It's what we might call these behavioral or psychiatric symptoms that can often occur with the disease. So I think caregiver programs have shifted over time to try to provide caregiver strategies maybe for dealing with some of those more challenging symptoms that can really be difficult for caregivers and broader family members.
So often when someone is caring for someone with dementia, it's the first time they've done it. It's like inventing the wheel for the first time. And one of the ways that support groups can be helpful is that others have been there, they have done that, and they can help you with that. So not only to hear you and to give you moral or emotional support, but also say, hey, I have an idea how that might help. And I, as a doctor, have some ways I can help, but I haven't experienced it myself as caring for someone. So it really is others who have experienced caring for those with dementia who I think can be the most valuable to someone who is currently confronting that as a care partner.
Yes, thank you all three. Some really important points there. We have a couple of very interesting audience questions I want to push to before we move on to our theme of research. And the first question that's come in, it's an interesting one. How can we protect the civil rights of persons that have Alzheimer's or related dementia and cognitive issues? What if you are concerned about not being included in decisions about your health?
Scott, you want to take that first? I think you probably are best equipped for that more than I am.
Yeah, I mean, I guess I've got a couple. It's a great question. I've got a couple thoughts here. I mean, one thing it makes me think of is the importance of people with dementia being part of advocacy for policy change. And I think luckily we've seen some great advocacy, for example, in increasing the federal budget for research for Alzheimer's. But I think it goes well beyond that. There are some great groups in Michigan. There's a relatively new group called Dementia Minds based here in Michigan that I think involve people dealing with dementia themselves being part of the solution. So providing education to the public, for example, about the stigma that they themselves have faced. I think we're seeing there's more organizations, like there's a dementia friendly Celine group that's been very powerful here in Southeast Michigan that's trying to lobby for thinking about how can we make public events maybe more inclusive of people with dementia. And they have like a special movie night at the Imagine Theater in Saline that specifically invites folks dealing with memory loss. So, and I think these kinds of issues have also come up. And how can we make public transportation or things like that? Another issue that I think is important to keep in mind is that financial exploitation disproportionately affects older adults and people with cognitive impairment. And so our partners at Wayne State University have a program called SAFE that's trying to help educate families about how can they avoid being taken advantage of, and if they have been taken advantage of, how can they help deal with the after effects. So I think thinking about these issues of kind of financial exploitation and management. So hopefully those relate at least some to these issues of civil rights that the astute questioner was bringing up.
It is a very interesting question, and it brings me back to my own clinic. When I make a diagnosis of dementia or the precursor to dementia, mild cognitive impairment in someone, I say right off the bat, don't let this disease own you, you own it. Okay. There's going to be a long period of time typically where this disease will progress over time and impair some of your functions. But when someone is initially diagnosed, that is not the case. And it's very important for me as a doctor to explain to the patient and to their spouse or to their child, whoever's with them, their care partner, this is what the future is going to bring, and we ought to be thinking about that. And it's important for you to understand that about the decision-making capacities you have now that you might not have in 4 years. And so these are planning issues, and this is why it breaks my heart when I hear about doctors say, you have dementia, I can't do anything for you. There's so much we can do to help you plan for what the future will hold for you year 1, year 2, year 5. And that gets back to the civil rights or autonomy and decision-making capacities of someone who has dementia. Lynette, anything you want to add here?
Absolutely. So I agree. I was thinking with my advanced practice nurse hat, you are in the driver's seat, right? And you want your decisions to be respected. And sometimes later on in Alzheimer's disease, you're not able to voice those opinions. So having those conversations up front, like when Dr. Paulson said, perhaps when you initially are diagnosed with mild cognitive impairment, and then revisiting that plan as well. So actually have it written out, having conversations about it so that you can make sure that your wishes are respected. I also want to talk a little bit about what Scott brought up, as far as I think you talked about busing and about something that was taking place in the movie theaters. Being very thoughtful and intentional and asking questions, our elected leaders, people who make decisions about busing or about, different laws and at the local level, it's really important to participate in voting, asking those who are running for office some of these questions. What do they know about Alzheimer's? What do they know about creating a safe environment? What are their thoughts about, listening to folks that bring these things to town halls? And so really looking at those trends and behaviors and making sure that we as citizens are thoughtful about who we elect as leaders and how they will address problems that come up. We talked about a lot of changes that might be taking place in the health arena over the next 20 years, but how is that going to impact us in the cities that we live in, and our thoughts about how we can protect older adults and keep them safe as we move forward. So I think all those things are important when you're thinking about how you want to contribute to society, who we want to work with and partner with, and really being thoughtful in advance about some of the things that we can do and people that we elect and people that we're going to be around.
Thank you all three for those very thoughtful answers. Just a quick time check, 12:47. We have just a few more questions to tackle. And before we move on to the topic of research, we have another audience question. How much are the use of opioids and antidepressants involved in increasing the likelihood of developing dementia or Alzheimer's?
Any medication that clouds one's cognition or makes someone less alert, particularly an older person, can lead to cognitive impairment. And that would include opioids. Some antidepressants can do that, and some other medications can do that. The use of opioids in our country is a huge issue, and the relationship between opiate use and dementia is not clear, to my knowledge. I think it's hard to sort of separate out the issue that might come with opiate use and chronic pain or stress or environmental issues on the one hand from dementia risk and dementia on the other hand. But there's no question that a medication like an opiate clouds one's cognition. So one of the things that I do when I see people in the clinic is I review all the medicines they're on, what they take, and see which of these might be contributing to their cognitive difficulties. We will often eliminate some medications. Other medications can affect the degree of sleep, et cetera. So we will look at that as well. I don't know if Scott or Lynette have any specific comments on the relationship between antidepressants or opioids and dementia.
Yeah, I think they're, to my knowledge, not seen as important risk factors for Alzheimer's specifically, but I do think, Hank, your point about polypharmacy is a great one. We certainly, Donovan Moss, one of our colleagues in psychiatry here, is a national leader in kind of doing research that recognizes that often older adults are probably on too many medications, and sometimes this happens if care is not coordinated. They see, one provider who had something, another provider who has another thing, and a lot of times those interactions can be harmful to not just cognition but physical health as well. So I think kind of being mindful that sometimes less can be more in patients where we're talking about multiple powerful medications at once.
I spend as much time trying to judiciously eliminate medications as I do adding medications.
Yeah, I see some nods there too. So let's move on to our final topic before we wrap up, which is research. My question...
Can we go for another hour, Ed? I think we could talk about research for an hour here.
We'll have to do like super fast responses to this. I think maybe we should schedule another live stream, really, to be honest. So my question here, what can you do to learn more about prevention of Alzheimer's and dementia? How can you help?
Well, let me focus right away on what we do at the Michigan Alzheimer's Disease Research Center. Firstly, our website, you can go to it. It's alzheimers.med.umich.edu. And Alzheimer's does not have an apostrophe. It's just alzheimers.med.umich.edu. You can see what studies we do. We have several dozen studies that range everything from observing people over time, looking for biomarkers so we can make more precise diagnosis, to doing electrical stimulation of the brain, to exploring how sleep affects Alzheimer's disease, to doing clinical trials for medications, to doing studies on how people respond when you give them the results of their disease risks. And that's one of the things Dr. Roberts is really well known for. And so these are all different kinds of studies, and you are welcome, particularly if you're in the state of Michigan, and we are a statewide center involving University of Michigan, Wayne State, and Michigan State. We would be delighted to provide you that help. Now, if you're outside the state of Michigan, there are many other Alzheimer's centers around the country, and I think the Alzheimer's Association is a good first point to go to if you're thinking about Alzheimer's. I did mention LBDA and FTD as other ones as well. I could talk forever about my own research, but I'm not going to do that. I'm going to turn it over to Dr. Jones and then Dr. Roberts.
That's a great point, Hank. I think we could talk for a whole nother hour about research. So I'll just add on to that. I completely agree with what's been stated so far. I think that social media is great. So perhaps following the Alzheimer's Center on social media. I'll say, so I have a professional page as well. And so on my social media, my lab, we take evidence-based literature and we put it into digestible amounts of evidence. And so in a layperson language. And so if there's a new study about how to manage your blood pressure, we take that and break that down. And we also share the link right underneath, right? And so we give you the information, but we also share the link if you want to read more. So I think it's important to also think about social media in addition to what we've talked about. Who can you follow? Where can you get digestible bits of information? And then when you have more time to follow up, you can click on that. Also, I want to I alluded to this earlier, we have to participate, especially women. We're more affected by Alzheimer's disease, those from communities of color. We have to participate in research. And I'm saying be a aware and purposeful participant. So whatever questions you have, if you have some concerns, there's a number. You can call the investigator, you can call IRB, you can call all sorts of folks, but really getting your questions answered so that you can actively participate and really be confident in the study that you're participating in and the results that are going to help. Maybe not us right now, but in the next coming years is really important. So I'll just add social media and be thoughtful about participating in studies and research.
Yeah, I can just add, Hank mentioned our Michigan Alzheimer's Disease Research Center website. And within that center, our entry point is often what we call our mindset registry. So we have a registry that's very easy to sign up for. You can see there's an easy form to fill out on our website just to kind of get you in the door. And I think it's really up to you from there. There's no absolute requirement you have to take part in particular studies, but it at least lets you know what are your options for research studies that our center sponsors. And also by doing that, it also gets you in the know in terms of some of our center events. We've got a regular online seminar series. We've got some special events. I mentioned earlier some of the caregiver and education. So we've got a variety of programs that might be of interest. And Aaron Fox is our outstanding manager of communications who helps put out. We also have a monthly newsletter, and so things like that might be of interest to this audience. I would encourage you to check out our center website and the Mindset Research Registry in particular.
Well, thank you all three. The last question I have is probably the toughest, with only a couple of minutes remaining. But before we wrap up today, I'd like to ask all three of you if you have any key takeaways you'd like to leave with our viewing audience.
Most important, look at those modifiable risk factors. Think about the importance of exercise, eating well, sleeping enough, engaging with people, doing things you love to do. Those are important.
Thank you. Dr. Jones?
The only thing I would add to that is to think about your environment, thinking about secondhand smoke, thinking about stress, think about the things that you can modify in your environment as well in order to reduce your risk. So there's some things that we can stay away from, some people we can stay away from, and some situations that we can stay away from to reduce stress and maintain our mental health.
Yeah, I would just say it's been great to be part of this, and I'm glad we've kind of covered a wide range of topics. And I just hope that these kinds of discussions are part of a broader effort to really reduce the stigma associated with Alzheimer's and make it easier to just talk more generally about some of these issues that can be sensitive, and also just to raise public awareness of some of the resources we're talking about. I think a lot of times people don't know where to turn. So I would encourage folks, if there's anything you found of interest here, to share the information with friends, neighbors, loved ones. And I think there's a lot of great stuff out there that is not always disseminated as widely as we'd like.
Thank you. I think that's an excellent final thought, Dr. Roberts. If you look in the comments, you'll see lots of resources to share. The videos on all our social platforms from today's chat are shareable too. So thank you for joining us today. Thank you to our three panelists for a great discussion on the prevention of Alzheimer's. If you missed parts of this live stream, know that we will have it posted on our Michigan Medicine social channels. And finally, for more information on Alzheimer's resources, dementia, Alzheimer's disease, memory loss, you can go to www.uofmhealth.org/Alzheimer's. And as Dr. Paulson mentioned earlier, no apostrophe there, just Alzheimer's, uofmhealth.org/Alzheimer's. So thank you to our three experts, and thank you to our viewers as well. Have a good afternoon.